And it was really fascinating before my lecture to have a very comprehensive, get a comprehensive knowledge about the history. And it was wonderfully done by Niranjan. And as he said, every successful man can have a successful wife behind. And I think sometimes a successful consultant can have a successful wife in clinical microbiology behind him as the successful story. Anyway, the molecular diagnostic of tuberculosis, and you can now remember uh, he uses some words actually. As a microbiologist, I also like to use the word, this microorganism is so fascinating, but unfortunately not for the clinicians or for the patients, but microbiological point of view also, it is a really a fascinating, challenging organisms. I just touch on some characteristic features of these fascinating organisms because it matters when we want to diagnose them microbiologically. So this is an aerobic and an unmotile organisms have straight and or curved rods beaded, and as the described in the previous lecture, it contains a lot of lipids in its cell wall, mycolic acid, uh, which is actually which is one of the reason for the diagnosis of the disease, and also from the pathogenesis point of view, immunological point of view, it is the main factor why we can't immunologically control the bacteria also. Another most important thing is from the microbiological point of view, it multiplies very slowly and can remain dormant for decades. And the doubling time of the microorganism is 18 to 20 hours, right? So that's why we can't rapidly grow them like other bacteria in culture medias. And also the usual culture medias where we used to grow staph for other common organisms, we can't use usual conventional medias to grow them because it needs some specific uh, requirements to grow them on artificial medias. And just to touch on what we are going to diagnose, basically, as described, the Mycobacterium tuberculosis is a complex. It has a lot of species in it, and complicating complicating more, we have some other non-tuberculosis mycobacteria also. So when we want to diagnose them, we have a lot of challenges. The first thing is we need to isolate the organisms. After isolating the organism, then we need to confirm it as a mycobacteria, which can cause tuberculosis, or sometimes we need to give the diagnosis. It is a mycobacteria, but it is not tuberculosis. So then we will see what are the current methods of diagnosis and ideal testing for diagnosis. From clinical point of view, if you want to diagnose a disease, we need it very quickly. So the test has to be very rapid, and also it has to be very sensitive, and also to say this is tuberculosis, the test has to be specific. So an ideal test has to be very rapid, very sensitive, and very specific. But unfortunately, none of the tests I'm going to describe in my next slides have this ideal testing. So what is the current standard method or the gold standard of confirming Mycobacterium tuberculosis? So that is culture, as I described before. But unfortunately, culture is a very specific test, and it is also very sensitive, but unfortunately, it takes time. Usually, in a in a TB lab, we have to keep these culture media 6 to 8 weeks because some Mycobacterium tuberculosis take 8 weeks to grow. So it is a relatively slow process. What is the conventional faster method then? The conventional faster method is smear staining. It was described, it was discovered many 100 years ago, but still it is a very useful test, very simple, very quick. But unfortunately, doing AFBs or doing staining on direct samples, it is less sensitive than cultures. So that's why the molecular test has a role in diagnosing tuberculosis. So I will describe in my lectures, I describe in my next slides. So the molecular testing, the PCR testing or other molecular testings are in between. It is in between culture and in between staining. Another thing is we are in a very rapidly developing world. All the technologies, the molecular and the whole genome sequencing and a lot of newer technologies are emerging, but don't think in TB, the molecule, the molecular diagnostic in tuberculosis will give all the answers. That's why I said it is still a challenging disease for all humankind to diagnose them and also to treat them. And I will agree with Dr. Niranjan, this battle will persist many more years to come. So in this slide, this is just a summary about the pros and cons of the microscopy, culture, and the molecular testing. As I said before, the microscopy test results will, it is very simple, it is very easy, but the sensitivity is less. The quality of, the results will be depend on the quality of the sample and the presence of how much bacteria is in the sputum sample. So, and you need expertise, knowledge in laboratory. You need expert persons in the laboratory as well, because it is depend on the person who is performing the test. And the culture medias, basically, it is the gold standard. After isolation, you can do a lot of other things with the culture medias, but unfortunately, it is very time consuming. And the nucleic acid amplification methods or the molecular methods, it is quick, but it is not sensitive as culture methods. So it plays a in-between role when it comes for the diagnosis of tuberculosis. So now I will come to my main topic, the molecular diagnostic of tuberculosis. So first we have to know what are molecular tests. In a very simple way, the molecular test in microbiology, we are using to describe a test that detects pathogens, nucleic acids, or RNAs. And here the main point is this RNA or the DNA. If you talk about tuberculosis, it is a DNA bacteria. So they have some specific areas which is only specific for that species. Now, for example, if you want to tell using molecular diagnostic, this is Mycobacterium tuberculosis complex, we have designed tests in the laboratories. So we will detect the genes or the DNA molecule, which is only specific for Mycobacterium tuberculosis complex. So the test results will give a positive test results if this only if this specific area is present in the sample. And this is the very simple term to describe or define molecular test, but now it has gone, we have a lot of other, expansion of molecular testing also, like whole genome sequencing as well. Now we are in an era where we can express, or we can express the whole genome of a bacteria or a virus, which is very, very useful in detection as well as controlling the disease. All molecular diagnostic tests have 3 stages. That is, we need to extract the DNA from the sample, then we need to amplify the DNA, and then the last stage is we need to detect it. So in the laboratory, it is a very, the conventional PCR methods are very cumbersome. It is also depend on the skills of the technicians, and you have to specially design a laboratory to carry out molecular testing, because sometimes we have to prevent cross-contaminations to prevent giving false positive result. The last stage is the detection of the DNA molecule or the RNA molecule. For that, we use different methods. One is electrophoresis. One of the other method is line probe assays and the real-time detection, which is we are very commonly using these days. Other most important thing is, as I said before, conducting molecular diagnostic is also not a simple test if you want to do it in the conventional way. But now there are a lot of companies, there are a lot of pharmaceutical companies invested money in rapid diagnosis of TB using molecular methods. So there are a lot of commercially available rapid diagnostic, very easy to use molecular diagnostic testing. And one of the commonly using rapidly diagnostic of molecular based diagnostic test is GeneXpert. And there is another method to detect the presence of TB DNA in samples is line probe assays. But I don't think in Sri Lanka, the line probe assays are very commonly used. But MTB RIF test using GeneXpert machine, we are very frequently and very commonly using. And some of the algorithms, the diagnostic algorithms of tuberculosis also has changed because of this introduction of MTB RIF using the GeneXpert machine. So these are some, the picture description of the two methods we are using to show that the Mycobacterium tuberculosis DNA is present. This is a picture depiction of the line probe assays. As I said before, the first you have to extract the DNA, then you have to amplify the relevant gene or the relevant area in the gene, and then you have to show that the specific genes are present in the sample. So this is the very easy to use molecular technology. We are very widely using now in Sri Lanka. So this is GeneXpert MTB RIF assay. It is actually all the steps, as I said before, the extraction, the amplification, and the detection, all these steps automatically happen inside a cartridge. So the technician has the technician need to do, he or she need to process the sample and then just put the sample into this cartridge, and within 100 minutes, you will get a result. So this is how we use the MTB RIF to give you the results. So there are three ways. One is you can detect MTB, Mycobacterium tuberculosis complex. So the gene they are detecting is specific for the Mycobacterium tuberculosis complex, not only to Mycobacterium tuberculosis, all the complex we can detect. And also the rifampicin resistant is also detecting. And so you can get results, MTB detected, rifampicin resistant not detected, MTB detected, rifampicin resistant detected. And sometimes if the bacterial load is very low, it gives you results as MTB detected, but rifampicin resistant indeterminate. And in these scenarios, we have to be very careful. I think the rifampicin resistant in Sri Lanka is not that high. So if you get a result like this, you need to repeat the sample again, because usually due to the lack of, due to the small amount of DNA presence in the sputum samples, they can't carry out the test in a proper way inside the machine. So then they will give a result as rifampicin indeterminate. And if you get MTB not detected, it means the machine has not detected tuberculosis. But it doesn't mean the patient is not having tuberculosis. As I said before, the culture is the gold standard, and we don't have any test with 100% sensitivity and 100% specificity, and also giving the results in very quick time. So this is just a comparison of the molecular testing. So you can see the pros and the cons and what you will get by using these three methods. the molecular test and influencing the patient outcome. And I think that is the most important point here as clinicians. So how it influences the patient's outcome. So the one of the most important thing is definitely molecular testing, whether it is conventional PCR or PCR using gene expert machine, it will give an early diagnosis, which will improve the patient's outcome as well as public health control. I mean, controlling the disease, spreading the disease. And also the rapid results can result in prompt antibiotic treatment and also the isolation of patient, prevention of transmission, reducing hospital stays and better targeted contacted investigation. So if you have a diagnosis at the beginning, we don't have dilemmas. I think the most important thing in TB clinical diagnosis is it give a dilemma. I mean, basically it can present, the clinical presentation can be anything. So if you have early diagnosis, the unnecessary investigations we are going to do on patients will reduce. And also the other most important thing is it will give some clue about, it is an early indicator of antimicrobial resistance also. So in conventional methods, we know to treat the patients, we should have antibiotic sensitivity pattern. Unlike other conventional bacteria, as I said before, the tuberculosis to grow on a conventional media, it takes sometimes 6 weeks. So if you want to perform antibiotic sensitivity testing, again, it will take another 4 to 6 weeks to give you an accurate results. So that is not the clinician want. With the invention of this molecular testing, which has the facility on information on antimicrobial susceptibility also. So usually, as I described before, we can get the results early, not only on the main antibiotic, first line antibiotic, but you can get results on second line antibiotic, anti-tuberculosis drug also. And other most important thing is this test can be performed directly on the samples as well. So gene expert, so we are giving you the results, not on the isolates we are going to get from the culture media, but from the direct samples. Even the antibiotic sensitivity patterns, antibiotic sensitivity clues can get from these direct samples. It can be either sputum, urine, CSF, or any other body fluid. So just to touch on whole genome sequencing, I think this has the whole genome sequencing now. So if you want to diagnose a gene, I mean resistant gene, the most important thing is we are detecting only the already known genes. So if there is going to be another new gene which can confer resistance to rifampicin or any other drug, by this targeted molecular diagnostic, you can detect it. But if you can elicit the whole genome, then with a lot of new softwares, you can detect the new emerging resistant mechanisms also. And other most important thing is, as I said at the beginning of my lecture, there is no gold standard, there is no 100% sensitive or specific test. So the most important thing is, if you want to do the molecular testing, always you need to couple them with the conventional methods like AFB and culture also. As I said before, so when you are going to get a result, it says MTB detected, but rifampicin not detected. It means the rifampicin not detected. I mean, basically, it means, but we have already known about the rifampicin resistant genes. You have not detected the current rifampicin resistant mechanism, but there can be newer methods. So that is why it is very, very important to isolate the bug, because once you isolate the bug, we can do whole genome sequencing or other comprehensive genomic assessment, which may detect you newer resistant mechanisms. And mind you, the microorganisms are very fascinating, and the TB is also fascinating. They will definitely fight back. Definitely, we will have newer antibiotic resistant mechanisms also. And other most important thing is the false negatives. So as I said before, this is not 100% sensitive or specific. So if you have a clinical suspicion, high clinical suspicion of tuberculosis, you need to proceed with your clinical sense as well. I think that's it. My last word to you is the molecular diagnostic has changed diagnosis of tuberculosis in a big way, but use it very wisely and also couple it with the conventional test also. Thank you very much.